So we will get started. For those of you who don't know me, my name is Shui, one of the co-founders of Bite Medicine, and we are on our 58th webinar. I didn't think we would come this far, so it's been an absolute pleasure teaching all of you guys. Today we're going to be going over pulmonary embolism and DVT. They're two pretty similar things, which is why we've done them in one webinar. This will be part of our hematology series. Azim will be doing a lecture on Friday on neck of femur fractures. Just a few housekeeping announcements. All our webinars are now streamed via our website, app.bitemedicine.com. If you are having any issues, please do let us know in the chat. The Zoom link is available on the page just below the actual stream. So you should be able to find that if you are having any issues. Yeah, I can see there's already a few questions, something about guidelines, warfarin to DOACs. We'll go into all of that. What shampoo do I use? We can discuss that at the end. Cool. If you do have any questions throughout the webinar, just drop them in the Q&A, and Azim is around, or I'll try my best to answer them as well. So the aim of today is to cover PE, DVT, the pathophysiology, the risk factors, the management. We actually did a webinar on PE back in April, actually, and that was our 7th webinar. So we're now 51 lectures later, and we are doing it again because the guidelines have changed, and this is something you need to know for your exams. So there's been a fair few things which have changed with regards to the management of PE and DVT. The guidelines changed in March 2020 and March or April 2020, and we're going to go over what those changes are. We'll cover all the high yield facts that you need to know for your exams, and this should not take longer than hopefully an hour or so. As always, the slides are up on the website and the recording will be up hopefully in the next 24 hours. So this is our first case. Have a read and let me know if you're worried or not worried. So we have an elderly lady who's come in with pleuritic chest pain and shortness of breath. History of right-sided mastectomy for breast cancer a year ago. She's not on any medications and a BMI of 27. Those are her observations. So you guys are saying worried. Why are you worried? What's the big deal? Yeah, so she's hypotensive, she's tachycardic, she's breathing fast, she's tachypneic, she's hypoxic. So, you know, there's a lot, pretty much all of these observations are deranged except her temperature. And it's even more worrying in the context of someone who's, you know, fairly old. So good that you're all worried. Taking the case, really have a good read of it, because the question that's coming up requires you to understand what's going on in her background. But yeah, please do not answer the questions in the chat. I will bring up Menti and you can answer them on Menti. So if you go to menti.com and put in the code 268674 and answer which of the following risk factors does this patient have for developing a pulmonary embolus? Okay, P is pulmonary embolus, if you didn't know. The fact that she's female, previous breast cancer, 65 years old, BMI 27, and previous surgery. So she had the surgery 1 year ago, in case you forgot. Just looking at the Q&A again, someone's asked, are there certificates for the sessions? And we've temporarily paused the certificate scheme, but we are looking at potentially reopening it in the near future. Okay, I'll give you a few more seconds on that before we reveal the answers. So knowing the risk factors for P is really important for your exams. Okay, good. So we've got most of you going for previous breast cancer. Why is that the correct answer? So 44% of you went for previous breast cancer. Why is that the correct answer? Any thoughts in the chat? So yeah, it's actually the wrong answer. 65 years old. Breast cancer is not the correct answer. Let's explore why. So being female is not a risk factor. She's had previous breast cancer, but it has to be active cancer. So she's, this depends on what guideline you read, but NICE state active cancer. She's had cancer a year ago and she's had a mastectomy. She's not on any medication, as the case stated. So she's not even being treated for cancer. Her cancer is finished, you know, she's had the surgical treatment for it. So you need to have active cancer, not just previous cancer. That's not a risk factor. Age, elderly, being elderly over 60, according to NICE, is a risk factor. Obesity is a risk factor. So BMI above 30. Previous surgery is a risk factor, and according to NICE, should be within the last 2 to 3 months. This patient had surgery a year ago. Obviously, having surgery a year ago is not going to be a risk factor for a pulmonary embolus. It's just too long ago. Good, so I hope that all makes sense. The key thing is, with breast cancer and with surgery, they need to be risk factors which have occurred within the last couple of months, according to NICE. And that's why age was the correct answer here. Going back to the case, so we've got an elderly lady. She has sudden onset shortness of breath and pleuritic chest pain. So if this presents, this is a very common presenting complaint in the emergency department. I've seen this, and I'm sure Azim's also seen this tons of times. What differential diagnoses do you need to consider in anyone presenting with sudden onset shortness of breath and pleuritic chest pain? Good. Pneumothorax, anything else? So we've got PE, pneumothorax, pleurisy, pericarditis, pneumonia. Good. These are all good risk factors. MI doesn't really present with pleuritic chest pain. If it's pleuritic chest pain, that actually makes MI less likely. But elderly presenting with chest pain, shortness of breath, obviously you do need to consider MI. The fact that she had surgery a year ago and that she's had breast cancer, which is now cured, is not a risk factor. The fact that she was not on any medication suggests that she does not have active cancer. And you all picked up that this patient is not doing well. She's unstable. So yes, some more good differentials in the chat. COVID is another good one. Okay, definition. VTE, venous thromboembolism, is any thromboembolic event occurring within the venous system, including a DVT and PE. So when you see venous thromboembolism, all that basically means is it's an umbrella term encompassing DVT and PE. I mean, the definitions are fairly straightforward. Deep vein thrombosis, thrombus, which is another name for a clot in a deep vein, which partially or completely obstructs blood flow. So deep vein thrombosis is not the same as a thrombus within the superficial veins. They are treated differently. So DVT is different, okay? It's within the deep veins. Pulmonary embolism is one or more emboli. Most typically arises from a DVT, and it obstructs the pulmonary arterial system. Epidemiology, so VT is the third most common cardiovascular disease after MI and stroke, and then PE is very common. So 50,000 cases in 2013 to 2014. So this is common. You're definitely going to see this as a medical student, as a doctor. So you need to know it pretty well. Now, some of you are asking how does obesity cause a risk? How is that a risk factor for PE and DVT, etc.? So we're going to go into that now. Virchow's triad. This is going back to sort of your first, second year pathophysiology. It consists of 3 components: hypercoagulability, venous stasis, and endothelial damage. Any one of these domains, if there is a dysfunction in any one of these domains, then you are predisposed to forming a clot. So if we take hypercoagulability, that basically means increased platelet adhesion and clotting, okay? So your platelets tend to clot more, your coagulation factors tend to clot more, you're at risk of forming a thrombus. Venous stasis, well, obviously, if you have blood which is static, which isn't flowing properly, that's going to predispose you to forming a clot. Blood flow is normally laminar, and that means that all of your clotting factors and your platelets are dispersed evenly. If that blood flow is disrupted and the blood starts to stall, then those platelets are going to start to adhere to one another, your coagulation cascade will become activated, and you will form a clot. That's why immobility is a risk factor for DVT and PE. Endothelial damage. The endothelial cells normally prevent thrombosis. They secrete things which inhibit the coagulation cascade. If you have anything which damages the endothelium, then that's going to predispose you to forming a clot. So on the next slide, we have all of the risk factors under each of these domains. But if we started with hypercoagulability, can you name a few conditions which fall under this domain? What conditions make you hypercoagulable? So antiphospholipid syndrome, pregnancy, contraceptive pill, polycythemia, very good. Yeah, APS. Venous stasis, well, I said immobility, but more specifically, what predisposes you to, yeah, so post-surgeries, we've said, that's the most common one. Long haul flights is the other common one. And when you're in the emergency department and you have anyone presenting with pleuritic chest pain, you need to ask them, have you been on any long haul flights recently? Have you had any surgery recently? These are important risk factors to ask about in the history. And endothelial damage. What conditions cause endothelial damage? Smoking, yes, good. Yeah, if you iatrogenic procedures, sepsis as well is a big one. So if you go back to my sepsis lecture, we discussed disseminated intravascular coagulation. The inflammatory process in infection can damage the endothelium. Good. So for a DVT, the thrombus typically forms in the deep veins of the legs. Okay, that's going to be your most common location, is within the legs. For a PE, the thrombus typically embolizes from a DVT within the legs. The thrombus rarely develops within the pulmonary vasculature. It usually embolizes from a DVT in the legs. Okay. And this is Virchow's triad, and I think you pretty much nailed all the risk factors. So hypercoagulability, active cancer, the inflammatory mediators and chemicals secreted by cancer cells can activate the coagulation pathway. How is estrogen linked to hypercoagulability? What's the mechanism? So estrogen increases your clotting factors, okay? So when you have high levels of estrogen, you have more transcription of your clotting factors, and therefore you are prone to forming thrombi, and therefore prone to forming DVTs and PEs. In pregnancy, you have an increased risk of 4 to 5-fold compared to someone of the same age who isn't pregnant. So pregnancy is a big risk factor. Others include the oral contraceptive pill and hormone replacement therapy. Nephrotic syndrome, that's one we didn't mention. How does nephrotic syndrome cause hypercoagulability? It's because you lose your anticoagulants through your kidney. Okay, nephrotic syndrome, your glomerulus gets damaged, and then you lose your anticoagulant factors like antithrombin 3. You lose them in your urine, so you then become more susceptible to forming clots. And then the thrombophilia is like factor 5 laden, antiphospholipid, etc. Sepsis more typically causes endothelial damage, but it can put you in a hypercoagulable state as well. Venous stasis, recent surgery within the last 2 to 3 months, according to NICE. immobility, elderly, obesity. Okay, so if you're obese, you're going to be less active on the whole, and that's going to predispose you to venous stasis, long haul travel, as we mentioned. And finally, endothelial damage, so trauma, previous DVTs will damage the endothelium, and any iatrogenic procedures. Good, so that's your Virchow's triad. Now we're going to focus on PE specifically. So going back to everything we've discussed so far is applicable to DVTs and PEs. All of this puts you at risk of thrombus formation and therefore forming a DVT, which will potentially then go on to embolize and become a PE. But now I want to focus on PE specifically. So the pathophysiology here is you have an embolus, which then lodges in the pulmonary vasculature. If you have a clot within the pulmonary arterial system, that's obviously going to push your vascular resistance up. And if you have increased pulmonary vascular resistance, that's going to lead to right ventricular heart strain. Eventually, if the resistance is high enough and the strain is high enough, you're going to get right-sided heart failure, which is known as cor pulmonale. So cor pulmonale refers to right-sided heart failure secondary to a respiratory cause. So in this case, the respiratory cause is a pulmonary embolus. If your right heart starts to fail, eventually that might lead to a cardiac arrest, and therefore patients presenting with a massive PE, so a large pulmonary embolus, are at risk of cardiac arrest. And that's why you need to act quickly with these patients. And in particular, in this case, we saw the patient's tachycardic, she's hypotensive. So this is a typical patient who could then go on to develop cardiac arrest. So you need to act quickly. The point is, the pulmonary embolus increases your pulmonary vascular resistance, which eventually leads to heart failure. So what symptoms do we typically see? Pleuristic chest pain, that's your classic. These patients have chest pain on taking a deep breath in. They're dyspneic, so they're breathing fast. Cough or hemoptysis. Fever is seen in about 10% of patients. And syncope is a red flag symptom. So if the patient has collapsed, that means they have significant heart strain. Okay, it means their heart is not able to perfuse their brain properly, and that's going to lead to syncope. So that is a red flag symptom, and that means there is a significant PE causing significant strain on the heart. Tachycardia is a very common finding in PE. What's the most common rhythm that you see in a pulmonary embolus on ECG? Sinus tachy, good. So everyone said sinus tachy. I'm glad no one said S1, Q3, T3. So we'll go on to the ECG findings. There's something called S1, Q3, T3, but that's only seen in a minority of patients. I think it's something like 10%. Patients will be hypoxic, obviously because they've got a clot in their lungs. They may be hypotensive if their heart, if they're going to heart failure. In particular, if their blood pressure is less than 90 systolic, that suggests a massive PE, and that is a red flag feature. If their JVP is elevated, again, that suggests cor pulmonale, and that's the red flag feature. They may have signs of a deep vein thrombosis, such as a swollen and tender calf. So someone asked, can they go into cor pulmonale acutely? So yes, this is acute heart failure secondary to a pulmonary embolus. So once you've figured out, once you suspect that the patient has a pulmonary embolus, you have a patient who's come in with classical features of a pulmonary embolus, you then need to calculate something called their Wells score. These are the features according to NICE. So if they have clinical signs and symptoms of a DVT, you get 3 points. If PE is a #1 diagnosis or equally likely, you get 3 points. And then there's a bunch of other sort of risk factors, and you get points for each of those. I'm not particularly going to go into each one in depth because you can just read that on the slide. But what I will ask is, what is the cutoff for the Wells score? What score of Wells would make you think that the patient has a PE? So everyone's gone for 4, one person's gone for 5. So is it 4 or 5? Interesting. So it's greater than 4 is a likely PE. Less than or equal to 4 is an unlikely PE. So I can see most of you went for 4. Some of you went for greater than 4, so that's good. The point is, if the patient has a well score of 4 on the dot, that means that they are unlikely to have a PE. If the score is greater than 4, it means they are likely to have a PE. Good. So let's move on to the next question. So the patient has had a chest X-ray, which is normal. Their ECG shows sinus tachycardia. What is your next investigation? So this is why now you need to think about what the patient's well score is. But you don't really need to know it in depth. You just need to think, is this likely to be a PE or is this unlikely to be a PE? Because that will guide your next investigation. There's a few questions in the Q&A. Let me just have a look. So how do you assess a JVP? We can discuss that at the end. How is obesity a risk factor? So we discussed that. It's from venous stasis. Okay, let's have a look at what you guys think. CTPA. Interesting. Why not D-dimer? Surely it should be D-dimer because that's the test that tells you if a patient has a PE or not. Yeah, good. So the answer is CTPA. If the patient is likely to have a pulmonary embolus, you don't really need to bother measuring the D-dimer. You can just go straight to doing a CTPA. So this patient's well score is 4.5. Okay, I mean, you didn't really need to know that. The fact is, it's obvious from a presentation that this is likely to be a PE. She's coming with pleuritic chest pain. She's short of breath. She's tachycardic. She's hypotensive. She's elderly. So she ticks a lot of boxes for a PE. If you strongly suspect a pulmonary embolus, then the next investigation to carry out is a CTPA. If you think that this might be a PE, but the well score suggests it's unlikely, then you do a D-dimer. You only do a VQ scan in certain instances. Okay, VQ scan is actually rarely carried out. I've only seen it carried out on a handful of occasions. CTPA is pretty much available in most hospitals, even out of hours. Okay, so most hospitals do have access to a CTPA. Pulmonary angiogram is different. It's what used to be done a while ago. It's an invasive procedure which involves inserting a line through the groin into the pulmonary vasculature and then injecting contrast. It's like a coronary angiogram, but for the pulmonary vasculature. It's way too invasive, takes longer, requires specialist use. So it's not typically carried out, and a full blood count won't really provide you with any information at all. Just going back to the well score. So her score was 4.5 because the PE is a #1 diagnosis. So she scores 3 for that, and she scores 1.5 because she's tachycardic. So her score is 4.5. So how are we going to investigate a PE? Always split it up into bedside bloods, imaging, and special or further tests. So ECG, the most common rhythm you're going to see is sinus tachycardia. You might see right bundle branch block and right axis deviation. So these two things together suggest right heart strain. And you might see S1Q3T3. So we'll come on to S1Q3T3 in a bit. You want to do an arterial blood gas because if they're hypoxic, you want to check their PO2. They may be in respiratory failure, which again is a bad sign because it means they're not oxygenating properly. Typically, you would do a chest X-ray in these patients. You may rarely see this wedge-shaped opacification because you can sometimes get an infarct in the lung. The infarct in the lung appears as a wedge-shaped opacification. But the main reason actually to do a chest X-ray is to rule out other causes like a pneumothorax, because it'd be silly to take the patient for a CTPA when you could have just done a chest x-ray and found that they had a pneumothorax in the first place. And I have seen that happen before. You know, people jump straight to doing a CT without doing a chest x-ray, and it just turns out the patient had a pneumothorax. That's why it's always important to think of the differentials in your head. If the patient's very unwell and you don't necessarily want to take them to CT straight away because they're too unstable, then in A&E, what they might do is do a bedside echocardiogram. And if there is a massive PE, you can see evidence of right ventricular heart strain. So you can visualize that on the echocardiogram, but it's not necessarily a routine investigation. Your diagnostic investigations are going to depend on what your Wells score is. So if you have a high probability of PE as per the Wells score, then you do a CT-PA. If the probability is low, then you do a D-dimer, and you only do the VQ scan in certain circumstances, which I will come on to. So this is just a simple flow chart to understand it. If you suspect a PE, the first thing you're going to do is calculate the Wells score. So if they have a high probability, you then move on to doing a CT-PA straight away. And if that confirms a PE, that's great, you treat it. If it doesn't show a PE, that's fine, then you don't need to treat them for a PE. If the probability is low, as per the Wells score, the next thing you do is carry out a D-dimer. If the D-dimer is normal, that's it, that's the end of your investigations for PE. If the D-dimer is raised, then you do a CT-PA, and as before, if they have a PE, you treat it. If they don't have a PE, you don't treat them for a PE. What is a negative predictive value of a D-dimer? So if my D-dimer is normal, what does that actually mean? My D-dimer is normal, what are the chances that the patient does not have a PE as a percentage? Okay, so that's known as a negative predictive value, and it's 95%. So if the D-dimer is normal, you can say with 95% certainty, this patient does not have a clot. So it's a very good rule-out test, but a very bad rule-in test. Okay, that's what's always said in the emergency department when patients come in with a pulmonary embolus. If the D-dimer is normal, that's great, because you can say with good amount of certainty that they don't have a PE. But if the D-dimer is raised, there are tons of things which raise your D-dimer, okay? Any cause of inflammation, infection will push up your D-dimer. So it's not a great rule-in blood test. That's why if your D-dimer is raised, you can't treat them on the D-dimer alone. You need to go on to do a CT-PA. What does this ECG show? Yes, exactly. So it's a sensitive, but not specific test. So this is S1Q3T3. So let me show you why. So if you, S1 means in lead one, there is an S wave. So that's your S wave there. This is your Q, this is your R, and then your S is down here. So there's a prominent S wave in lead one. So that's S1. Q3 means there's a Q wave in lead 3. So that's your Q wave there. And T3 means there is T wave inversion. So that's your S1, Q3, T3. And that can be seen in pulmonary embolus, but it's pretty rare. It's usually seen in about 10% of cases. Good, so let's move on. So this is a CT-PA, and here you can see the pulmonary embolus. The dark gray stuff is your clot, and the white stuff is your blood. So you can see a big clot there, and what's that known as? What do we call that type of clot in the context of a PE? Saddle embolus. Good. So saddle embolus is a massive PE. If you see that, then you're worried. It means your patient is at risk of having basically a cardiac arrest imminently. And they may well need, well, they probably will need thrombolysis if you see that. So this is where we need to talk about a VQ scan. So some of you said you do a VQ scan in pregnancy, which isn't quite correct. The guidance isn't clear, really. This is what NICE and the Royal College of Obstetrics and Gynecologists say. If you suspect a PE in pregnancy, if they have clinical features of DVT, do an ultrasound of the legs. If the DVT is confirmed, you don't need to do anything else. You just start anticoagulation. If they do not have features of a DVT, then a VQ or a CTPA scan can be performed, but that depends on local guidelines. So the Royal College of Obstetrics and Gynecologists do not actually state whether you should do a VQ or a CTPA scan. They say it depends on your local guidance. So it's not that clear cut. If the chest X-ray has features suggestive of a PE, then you should progress to doing a CTPA. Which of these carries a bigger risk to the baby, a VQ scan or a CTPA scan? So most of you gone for a CTPA. So the VQ scan carries a bigger risk to the baby. The CTPA scan carries a bigger risk to the mother. That's why it's such a confusing thing and there's no clear-cut guidelines. So the CTPA in pregnancy carries a greater risk to the mother, in particular to increases the risk of breast cancer. That's because during pregnancy, obviously, the breast tissue increases in size, and therefore if you expose it to radiation, it's going to be particularly sensitive to that. A VQ scan increases the risk of childhood cancers. So it's you need to balance the risks and the benefits. And as I said, the above is based on the RCOG guidelines, and it's not particularly clear. The instance when you would do a VQ scan over a CTPA is if the patient is allergic to iodine contrast. If they're allergic to iodine contrast, they can't have a CTPA, and therefore they need to have a VQ scan. Good. Let's move on to the next question. CTPA confirms a PE. Which of the following would you start in this patient? So remember this patient, remember what the clinical state of the patient was. So warfarin, low molecular weight heparin, warfarin and low molecular weight heparin, apixaban or alteplase. I'm just looking at some of the questions. What's S1Q3T3? So we've gone into that. How do you get to respiratory alkalosis in PE? Or you can do if patients are hyperventilating because they're breathing very fast, they're breathing off their carbon dioxide. Was the ECG we saw a broad complex tachycardia? No, it wasn't. Okay, let's have a look at your answers. So we've got a split. No one's gone for warfarin, interestingly. And there's a split between low molecular weight heparin and alteplase. So why would you give low molecular weight heparin? Because that's the most popular answer. 37% of people, of you guys went for that. So why would you give them low molecular weight heparin here? So remember, what was wrong with the patient? Were they well or were they unwell? The patient was hemodynamically unstable. They had a blood pressure of 85 and the heart rate was high. So what do they need, thrombolysis or do they need anticoagulation? So they need thrombolysis. So it doesn't matter what the guidelines, if it's old guidelines or new guidelines, if the patient is unwell with a PE and they have hemodynamic instability, you need to thrombolyze them. So alteplase is what you need to give them. That's why that's the correct answer. So remember, going back to the case, she had a heart rate of 105 and a systolic blood pressure of 85. She was unwell. She's hypoxic as well. She's breathing fast. You need to thrombolyze this patient. Anticoagulation will not be good enough to treat her. So as I said, the patient requires thrombolysis. That automatically rules out all of these options because all of these are anticoagulants. Alteplase is a thrombolytic agent. What is the first line anticoagulant that you would use if the patient was stable? So would you use warfarin, low molecular weight heparin, or apixaban? We've got some DOACs. We've only got DOACs there. Okay, we'll come on to that. So in a massive PE, thrombolysis needs to be conducted, most typically alteplase. And the way you figure out if the patient has a massive PE, obviously the imaging will help, but it's looking at the clinical state of the patient. Are they tachycardic? Are they hypotensive? Are they in respiratory distress? All of these things suggest that the patient needs urgent intervention with a thrombolytic agent. Some of you might be thinking, what is thrombolysis? How does it differ from anticoagulation? So there's always three things when you think of, trying to break up clots or prevent clots. So antiplatelet agents, which act on the platelets and stop the platelets sticking together. And that's something like aspirin or clopidogrel. You have anticoagulants, like these things down here, low molecular weight heparin and a DOAC. DOAC stands for direct oral anticoagulant. These things act on the coagulation cascade and they inhibit various coagulation factors, depending on what specific agent you use. Thrombolytic agents act on the fibrinolytic pathway. So they activate the fibrinolytic pathway. That's the pathway which actually breaks up clots through plasmin. So thrombolytic agents are colloquially known as clot busters. They actually go and they break up the clot. That's why this is so important if the patient has a massive PE to give them a thrombolytic agent. In a non-massive PE, according to NICE, the guidelines have now changed. A DOAC, also known as a direct oral anticoagulant, is first line. So either rivaroxaban or apixaban. Low molecular weight heparin or warfarin may be used if the patient is intolerant to a DOAC or if there's evidence of renal impairment. So you can't use DOAC. You can't use a DOAC if the patient has significant renal failure. The length of treatment depends on whether the PE is provoked, unprovoked, or if there is underlying active malignancy. So if the PE is provoked, NICE say consider stopping treatment at 3 months. And if it's unprovoked, they say consider continuing beyond 3 months. And they leave it at that. They're not any clearer than that. In clinical practice, typically unprovoked patients are treated for 6 months, but this depends on the clinician. If the patient has active cancer, NICE say treat for 3 to 6 months. Now, what's the difference between a provoked and an unprovoked PE? Provoked PE is one where there's a transient risk factor within the previous 3 months, such as immobility, such as surgery, such as trauma, pregnancy, etc. An unprovoked PE is one where there isn't a transient risk factor within the last 3 months. So the first thing is if it's massive, you give them thrombolysis. If it's non-massive, you give them anticoagulation, of which the first line option is a DOAC. The length of treatment depends on whether it's provoked or unprovoked. That's the basic principles of managing a PE. There are some additional treatments for a PE that you don't really need to know much about, but they may crop up here and there. I doubt you'd be tested on them in your exams. But if patients have recurrent PEs, you can put a filter in the inferior vena cava to stop those clots embolizing from the legs up to the lungs. So it's like a mesh which catches the clots before they get to the lung. If the patient needs thrombolysis in the case of a massive PE, for example, instead of giving them systemic therapy through a vein, through a cannula rather, you can actually direct a catheter into the pulmonary vasculature and give directed thrombolysis. And if the patient can't tolerate thrombolysis or thrombolysis has failed, you may consider surgical embolectomy, where you go in surgically and try and remove the clot. Again, these are sort of your niche treatments, which will be done in specialist tertiary hospitals that you don't need to know much about. Let's move on to the next question. What additional investigation should you carry out in this patient? So CT head, abdominal ultrasound, CT abdomen pelvis, abdominal x-ray, or none of the above? Just looking at the Q&A, so I think Azim's getting to quite a few of your questions, so thank you. Okay, so we've got a good split here. CT abdomen pelvis or none of the above. Okay, so why CT abdomen pelvis and why none of the above for those of you who went for either of those options? Good, okay, so you guys know, it seems like you guys know the guidelines quite well. CT abdomen pelvis was the old guidelines. So the answer is actually none of the above. And this is why we wanted to redo this lecture, because the guidelines have changed with regards to follow-up as well as management. So in the previous guidelines, if the patient had an unprovoked PE and they are above 40 years old, then you need to do a CT abdomen pelvis to look for cancer. In the most up-to-date 2020 guidelines, they state you should examine the patient, you should do some blood tests. If there's no evidence of cancer, you do not need to do any further imaging. Okay, so that's the most latest guidelines. And this is essentially what NICE say in a nutshell. So investigations for cancer, every patient should be examined. So every patient with an unprovoked PE should be examined and have a full set of blood tests, because you need to try and figure out why, people don't just have PEs for no reason. There may be an underlying reason, and you need to try and look for that, because they may have an underlying malignancy, for example. So you examine the patient, you do a full set of blood tests. If those are all normal and there's no evidence of cancer, then you do not need to further investigate the patient. The old guidelines said all patients with an unprovoked PE above 40 should have CT imaging, particularly of the abdomen and the pelvis, to look for a malignancy. So that's for cancer. For thrombophilia, so these are your hereditary conditions which increase your risk of clotting. You can check antiphospholipid antibodies if they've had an unprovoked PE and where there is a plan to stop anticoagulation. You can do a thrombophilia screen looking for things like factor V Leiden, looking for things like protein C, protein S deficiency. If there's an unprovoked PE and a first-degree relative who's had a PE and there is a plan to stop anticoagulation. The reason this caveat here is where there is a plan to stop anticoagulation is added in is because if you're planning to put the patient on long-term anticoagulation, say lifelong, there's no real point in checking these things because it's not going to change your management. If the patient has antiphospholipid syndrome, you're going to put them on lifelong anticoagulation anyway. So if your initial plan was to put them on long-term or lifelong anticoagulation, then you don't necessarily need to screen for thrombophilia because it won't particularly change your management. And remember, provoked PE is one where there's a risk factor within the last 3 months. Unprovoked PE is one where there isn't a transient risk factor in the last 3 months. And these guidelines are referring specifically to unprovoked PEs, where you're trying to look for an underlying cause, such as cancer or such as thrombophilia. Complications, core pulmonary, as we've discussed. Obviously, if you're having a clot in your pulmonary arteries, then you're at risk of forming pulmonary infarction. Cardiac arrest, as we've discussed, and heparin-associated or heparin-induced thrombocytopenia. So this is for patients who are treated with, in particular, low molecular weight heparin or unfractionated heparin. Heparin can induce, in a small number of cases, an autoimmune response against platelets, and that can cause your platelet count to drop very rapidly. It's quite rarely seen, though. And these are your differential diagnoses for a PE. So remember we said pneumothorax and pneumonia. They all present with shortness of breath. They can all present with pleuristic chest pain. The key differentiating factor in a PE is that you can get hemoptysis. There may be evidence of a DVT. Obviously, the risk factors are different. I'm not going to go into this in too much detail, but the key point is PE can be confirmed on CTPA, whereas a chest X-ray should be able to pick up the pneumothorax or the pneumonia. And that's why it's so important to, if you can, do a chest X-ray before doing a CTPA. And often radiologists, when you try and book a CTPA for a patient with a suspected PE, will ask you, have you done a chest X-ray first? And if you haven't, then they may well not allow you to progress to doing a CTPA until you've done a chest X-ray. So that's a little tip for when you are junior doctors. Okay, so next case, hopefully we'll wrap up in the next sort of 10 minutes. We have a 50-year-old man presenting with a swollen and painful right calf. So you can see it's significantly more swollen compared to the left. It's a bit more red. He's an active smoker and currently being treated for lung cancer. Are we worried or not worried about this patient? Okay, some of you said worried, some of you said maybe not. He's pretty stable. This is, I mean, this is a DVT, right? We know the lecture's on deep vein thrombosis. This guy's got a DVT. DVTs, I mean, the patient's stable in terms of his observations. Yeah, he's got a swollen leg, but I wouldn't be too worried about this. Again, this is a very common presenting complaint to the emergency department. And these are typically well stable patients. How does it present? It presents with unilateral calf pain, erythema, swelling. Tendon swollen calf. There may be evidence of peripheral edema and distension of superficial veins. But the main finding is that you're going to have a swollen calf compared to the contralateral one, and it's going to be red, it's going to be painful, it's going to be quite tense when you press it, and that is your key finding. And as you can see, that's the swollen leg there. Someone's asked a very good question. How do you differentiate this from cellulitis? That is coming up on our differential slide. The Wells score for a DVT is slightly different. So again, it includes very similar factors: active cancer, immobility, calf swelling, if there's evidence of superficial vein distension, if the entire leg is swollen, etc. And you get a point for each of these. If you suspect an alternative diagnosis like cellulitis, then you get minus points. You tot all of these points up. What is the threshold for a DVT on the Wells score? What would make you think that the patient has a likely DVT? So you've got greater than 2, 2, mix of greater than 2 or 2. So it's greater than 1, i.e. 2 and above, is a likely DVT. 1 and below suggests it's an unlikely DVT. So you need to learn these thresholds. These are important. They'll come up in your exams. They'll come up in clinical practice. So the patient has a Wells score of 2. What is your next step? So if this patient had a Wells score of 2, what are you going to do next? D-dimer, CTPA, duplex ultrasound, chest X-ray, or discharge them home. Let's see what you think. So we've got good duplex ultrasound of the leg. Yeah, so it's very similar to the management of PE. So remember, if the diagnosis is likely, you progress to imaging. If the diagnosis is unlikely, you progress to D-dimer. The Wells score is 2. Remember, we said a score of greater than 1 is a likely DVT. So this patient needs imaging of the leg. There's no reason to image the chest because they've come in with a problem of the leg. If a patient comes in with a swollen leg, you need to image the leg. So that's why ultrasound is the correct answer. And that's kind of what we discussed here. So duplex ultrasound of the leg is the first line in those with a Wells score of above 1. If the score was less than or equal to 1, then you do a D-dimer. Of course, you can't discharge the patient because they need further investigation to figure out what's caused their swollen leg. So this all depends on your Wells score. If your DVT is likely, as we said, you need to do a duplex ultrasound within 4 hours, as that's your diagnostic investigation. If you can't do it within 4 hours, you offer them interim anticoagulation and perform ultrasound, usually the following morning. So in a lot of hospitals, it may be tricky to get a ultrasound within 4 hours. So in my hospital, it can be quite difficult actually. So you measure the D-dimer, you give them 1 shot of anticoagulation, you call them back the following morning, and you book them for an ultrasound to confirm whether or not they have a DVT. If the DVT is unlikely as per the Wells score, you conduct a D-dimer. If the D-dimer is normal, remember you can say with 95% certainty that they don't have a clot. If the D-dimer is raised, then you'll perform your duplex ultrasound. And if the ultrasound shows a DVT, you will treat them. One caveat to this, if the D-dimer result is not available in 4 hours, you should offer them interim anticoagulation. This is very rare. I can't think of any hospital where you do a D-dimer and you would not get the result back in 4 hours. Usually you can get the result back even, within sort of 20 minutes to an hour. Okay, so this is just a flow chart to simplify and summarize things. So if we start with the likely side of things, the patient comes in with a swollen leg, you think they may have a DVT. The first thing you're going to do is conduct the Wells score. That's going to tell you whether or not they likely have a DVT. If the score is likely, and you can do a duplex ultrasound within 4 hours, that's great. You go ahead and do that, and that will tell you whether or not the patient has a DVT. Of course, if they have a DVT, you treat them. If you can't get the ultrasound within 4 hours because you're in a smaller district general hospital, you measure their D-dimer and you give them 1 shot of anticoagulation, and you try and do the duplex ultrasound within the next 24 hours. So as soon as you can, really. Usually that means calling the patient back the next morning. The patient is covered for a DVT because you've treated them with 1 shot of anticoagulation. They come back the next morning, you do an ultrasound, and that will tell you whether or not they have a DVT. If they don't have a DVT, you don't give them any more anticoagulation. If they do have a DVT, you treat them for that. If they are on this unlikely side of the algorithm, where it's unlikely that they have a DVT, you measure the D-dimer. If the D-dimer is normal, you need to think about alternative diagnoses. If the D-dimer is raised, then you go back into this pathway here of doing the ultrasound within 4 hours, okay? And if it's not available within 4 hours, then you go along this limb of the algorithm. So it's fairly straightforward. The point is, if you suspect a DVT, measure the Wells score. Based on that, you're either going to do an ultrasound or you're going to measure the D-dimer. That's the bottom line. How do you manage these patients? So it's anticoagulation, exactly the same as PE. So a DOAC is first line. Low molecular weight heparin or warfarin may be used if they're intolerant to a DOAC or if there's a renal impairment. Again, if it's provoked, you consider stopping at 3 months. If it's unprovoked, you consider continuing beyond 3 months. And if it's active cancer, you treat for 3 to 6 months. So exactly the same as PE. You're not learning anything new here. This is just a reiteration of what we discussed before. And remember, provoked means that there was a transient risk factor within the last 3 months. Someone's asked a good question about interim anticoagulation. So that will depend on your local guidance. But in my hospital, we either give them 1 dose of, say, rivaroxaban or 1 dose of a DOAC, or you can give them 1 dose of low molecular weight heparin. Investigations so following up a DVT, If the patient has had an unprovoked DVT, again, you need to look for an underlying cause. Could this be cancer? Could this be thrombophilia? And it's exactly the same as PE. So I'm not going to go into this again. But remember, you do not need to conduct further investigation if there is no evidence of cancer on the initial bloods and the initial examination. So that is the update in the NICE guidelines in 2020. It's exactly the same as what we discussed for pulmonary embolus. So I'm not going to go over this bit again. What are the complications of a DVT? So pulmonary embolism, that's the key one. Approximately 50% of patients, potentially even more, it depends on what papers you read, but approximately 50% of patients with a DVT will then develop a pulmonary embolus from that. Post-thrombotic syndrome describes a chronic change to the venous system where you've had the clot, and that can result in severe pain even after you've treated the DVT. Okay, that's known as post-thrombotic syndrome. Phlegmasia is where you have a massive DVT to the point where you're having a big clot, lots of inflammation, lots of edema. That's going to obstruct both venous inflow and arterial outflow, and that can actually lead to limb ischemia. Okay, so this is not good news. It's basically just a massive DVT, which can lead to limb ischemia. And again, you can have heparin-induced or heparin-associated thrombocytopenia if you start the patient on a low molecular weight heparin. Differential diagnosis. Someone asked a very good question. How do you differentiate DVT from cellulitis? And clinically, it can be tricky. They both present with a painful swollen leg. They both present with erythema. They both are tender, but in cellulitis, the borders of the erythema tend to be more defined. So the borders of the redness quite well demarcated in cellulitis. Additionally, in cellulitis, there's usually underlying evidence of infection. So fever, tachycardia, hypotension, they may have some of these features. The risk factors are different. So we're looking at Virchow's triad for DVT, but for cellulitis, the risk factors are typically those which increase your risk of infection. So elderly, diabetes, immunocompromised, lymphedema, all of these things are going to increase your risk of infection. And the key thing is also the investigations are going to be really helpful here. So the ultrasound is diagnostic for DVT, and that's going to show you if there's a clot or not. If it's just cellulitis alone without a DVT, so if it's just pure cellulitis, the ultrasound won't show a clot. Of course, in cellulitis, you'd expect your inflammatory markers to be raised, so your white cell count and your CRP. And that's how you differentiate DVT from cellulitis. Let's move on to our top decile questions. They wouldn't, you know, we always like to wrap up on these top decile questions. Hopefully it's fairly tricky. We'll see what you guys think. But if you go to menti.com and put in your username, then you should be able to get access to this question. And that reminds me, we have a quiz. We have a quiz on August the 19th, which is going to be a mixture of top decile questions and slightly easier questions. And there is a monetary prize to be won of £100 for first place, plus a lifelong subscription to Bite Medicine and a Bite Medicine mug. So please do join us on August the 19th. All you need to do is pop along as you do for these webinars and join our website. And if you log on at 5 p.m. on August the 19th, you will be eligible to compete. So the quicker you answer, the more points you get. Which of the following is the most common cause of thrombophilia? Protein C deficiency, protein S deficiency, factor V Leiden, antithrombin 3 deficiency, or prothrombin 20210A? I don't think this question is too difficult, actually. So I'm expecting a lot of you will get the answer right. And I can see there's quite a few questions in the Q&A. Thank you, Azim, for answering so many, but I will get to them at the end. Okay. That's a shame. A lot of you got it right. Good. Well, I'm proud. You all did very well. Factor V Leiden is the correct answer. Well done, Ebbs. Smashed it. Sadly, we don't have a prize, but you know, if you do come along on August the 19th and you come first, that's a £100 prize to be won. So do come and join us. Which of the following is the most common cause of thrombophilia? So factor V Leiden, that's where you have a mutated factor V, and therefore it's unable to be effectively deactivated. So you have an overactive factor V essentially. And to be honest, I'm going to have a separate lecture where we go into the coagulation cascade and all the different diseases. So I'm not going to go into this in much more detail. The answers are there. I'll cover it in another lecture when we go over coagulation cascade. So yeah, do tune in for that. As a recap, risk factor for thrombus formation is Virchow's triad. PE usually arises from a DVT. Well score is going to be absolutely key in directing your investigations. CTPA is the thing you want to do if you strongly suspect a PE. Duplex ultrasound is what you do if you strongly suspect a DVT. Newest guidelines say DOAC is your first line anticoagulant. Thrombolysis is used for hemodynamically unstable patients with a PE. And the other change in the guidelines is how you follow up patients with regards to investigations for cancer, as we've discussed. Please do check out our biomedicine question bank, which is online, and it follows a case-based approach as we take in these webinars. And evidence shows that's the best way to learn, and we've had some very positive feedback on that. We have cases on PE and DVT. We have a textbook which is quite thorough and takes you right through from your case history to your pathophysiology to your complications. Again, we have textbook sections on PE and DVT, so please do go check that out. And references, fill out the feedback form. Let us know what you think about the webinar integration and how we can make it better. We've been working around the clock to try and get new content out and make everything as smooth as possible. So your feedback is massively appreciated. Thank you all so much. You've been fantastic. I'll take some of your questions now. So what blood tests would you request? I assume you mean for investigating cancer. So you just do your standard full blood count, your clotting screen, liver function, bone profile, just your baseline bloods. Yes, good point. Please do join us on Friday. We have a lecture on orthopedics by Azim. Very exciting. So please do come and join us. In a lactating mother, which investigation is preferred, CTPA or VQ scan? That's a good question. I don't actually know. I imagine it would be a CTPA, but I'm not sure about the exact answer to that. What is meant by interim anticoagulation? So it's usually, you can give a DOAC or you can give low molecular weight heparin. You just need a one-off shot of anticoagulation to give to the patient so that they are treated in case they do have a clot, and then when they come back the following morning for their ultrasound, if the ultrasound shows they do have a DVT, you would continue the anticoagulation, you'd continue a DOAC in that case, and if it shows that they don't have a clot, then you don't give them any more anticoagulation. In pregnancy, do you give low molecular weight heparin for a PE? So yeah, typically you'd give low molecular weight heparin. Warfarin, you can't give because it's teratogenic, and DOACs, as far as I know, you tend to avoid them in pregnancy. Low molecular weight heparin is what you tend to go for in pregnancy. Are the updated guidelines regarding CT abdomen pelvis applicable to patients with previous recent malignancy too? So NICE doesn't really expound on that. And I imagine if they've had a malignancy a long time ago, you don't necessarily need to go in and image them. So I imagine it would be the same pathway that you'd follow. This is a good question. So when do you use a PESI score? So if a patient comes into the emergency department and you suspect a PE, you do the Wells score. Once you've diagnosed a PE, you can then do the PESI score, which predicts the mortality at 30 days. The reason you do the PESI score is if you're thinking about admitting the patient. So if you want to admit the patient to the wards, you can do the PESI score, and that will tell you how risky the patient is, how likely it is that they will die within the next 30 days. If they are in a high risk group, obviously you want to admit the patient and you want to observe them. If they're in a low risk group and they're clinically well, then you can discharge them. So that's when you would use the PESI score. Okay, let's take a couple more questions. When will the certificates be sent for the biomedicine group sessions? So I assume you mean for the national study groups that we've been doing. So if you finished all of your sessions, then all 6 of your sessions, then you should get a certificate of participation, I believe. But let me double check that. CTPA or VQ scan if the patient is allergic to contrast. So if the patient's allergic to contrast, then you would not do the CTPA, you would do a VQ scan. Good, I think we will wrap it up there. Finished at 6:05. That's not too bad. Hopefully I haven't kept you all too long. It's been an absolute pleasure. Thank you so much for tuning in. Please do tune in on Friday for a Zooms lecture and look out for our quiz on August the 19th. It's been an absolute pleasure teaching all of you guys. We will see you all later.